All right. Hi, everyone. Thank you for joining the Center for Learning Health System Sciences for our monthly Impact seminar. Before we get started, I'd like to cover a few expectations. Today's seminar will be recorded. You can enable closed captioning by hitting the Show Captions button next to the Raise Hand option in the Zoom menu. The public slide deck will also be made available on our website under the Education tab. I will post the link in the chat, along with a short questionnaire asking for seminar topic and speaker suggestions. Following the presentation, we invite you to raise your hand or type questions in the Q&A. In particular, we welcome questions exploring the many dimensions of impact that these ideas, technologies, and practices have on learning health systems. As a reminder for our upcoming LHS events, the next seminar will be on November 5th with Drs. Meera Vishwanathan and Jennifer Lin. And with that, I will turn it over to Dr. Chris Tinganelli to introduce our speaker.
Good afternoon, everyone. It's my distinct pleasure to introduce today's seminar speaker. Dr. Raj Srivastava is the Chief Clinical Programs Office at Intermountain Health, where he oversees 9 system-wide clinical programs which align clinical providers from across the enterprise to deliver evidence-based best practice in areas such as acute and ambulatory medical specialties, cardiovascular, and behavioral health. He is also a professor of research and oversees Intermountain's Healthcare Delivery Institute, which is a center for education, implementation science, and applied health services research. This is known as the HDI, and the HDI has accountability for the spread of clinical evidence-based practice across the integrated healthcare delivery system. He's a tenured professor of pediatrics at the University of Utah in the Division of Pediatric Hospital Medicine and a practicing hospitalist at Primary Children's Hospital in Salt Lake City. So with that, we look forward to hearing Dr. Srivastava's presentation entitled Health Systems, How Are They Setting Up to Spread and Sustain Evidence-Based Practices? Thank you and welcome.
Yeah, thanks, Chris. And sorry I didn't get back to you in the chat quick enough, but I really appreciate it. So I'm Raj Srivastava. And as Chris said, I have this really cool role at Intermountain where we get to oversee best practices. And as he said, I also see pediatric patients at the Children's Hospital, but my other role is working on the adult side as well. So it's which is cool. So I'm really excited to share this this story with you, spend a little bit of time. I thought I would explain a little bit about who Intermountain Health is. I know some people may know, some people may not. So Intermountain Health is going to be 50 next year. It operates in 6 states. It has 33 hospitals, 1 children's hospital of those 33, and of them, one of them is a virtual hospital. We have 67,000 people who work with us. And then in terms of physicians and advanced practice providers, you can see here, there's about 4,600 employed. There's about another 5,000 affiliated. So not everybody's employed. And one thing that has been really helpful in Intermountain's journey, especially on value-based care, is we have our own insurance plan. And so it has over 1 million members in it. Some people may know about Intermountain Health. I thought I would put this timeline. It really started as an organization from the Church of Jesus Christ of Latter-day Saints, where they said they ended up in the religion business and the hospital business, and they found that they owned 15 hospitals in the 70s. They decided that was not their business. They donated it to community, created a secular organization, and said, here's the thing, you have to be nonprofit and you have to be a model health system for the community. That has been amazingly helpful within Intermountain's journey. There have been some cool aspects over Intermountain's journey over the years, like the Healthcare Delivery Institute that I now get to run, but was started by Dr. Brent James, first Chief Quality Officer and one of my mentors. And then there's these clinical programs that kind of connect people together as well. And then we recently, like many of you, even some on this call, underwent a merger. And so right now, the piece I want to talk to you a little bit about is what are we focusing at Intermountain? So we have that system on the left. That's what that figure is. And then on the right, you can see this sort of famous quote that it takes 17 years for research to become standard practice. What's super cool about what I get to do and work with is we've got a couple of groups, clinical programs in the Healthcare Delivery Institute that really combine people to convene those discipline experts to say, what are those clinical best practices we should be focusing on? And then they get to lead the implementation of those models with those region service line leaders. And that's what has been exciting, is we've been able to cut that 17 years down quite a bit. So one of the groups that's really helpful in this work is those clinical programs. There are 9 clinical programs, and they cover everything that rolls up in clinical care. So they're the conveners. They help define those best practices. Some of them sit on those national societies and write those guidelines. The key is they help lead the implementation. And one of the things we're really working on is sustaining. A lot of us have experience in healthcare where, hey, we did that project, we did it, everybody took it on, and then a year later after we stopped, it's gone again. We are not doing that anymore. So we have committed to keeping sustaining going. And then if we're not sustaining, learning why. And one of the things that's super exciting about where we are at Intermountain's journey now that we're almost 50 is a lot of people, if you look on the right, see Utah. And they're like, yeah, well, you did it in Utah, but can you do it anywhere else? Now that we are those other multicolors, the reason they're multicolors is it's just our internal nomenclature. They're regions, so they're region presidents that all work in sync. But that's what we're going to try to do, is take what we've learned in one state and say, can you do it in 5 other states as well? So the Healthcare Delivery Institute is a pretty cool group that for a long time has really thought of themselves as, hey, we're the group that helps create the models. So we have the clinical best practice integration model I'll share in a minute. It is totally based in implementation science, quality improvement frameworks. Since that was one of my backgrounds and a group of us came together, we're like, we got to learn. So the only way to learn is have a framework and apply a lot of projects to the framework and see how to adjust the framework if needed and learn. And then we have a class, the advanced training program, that I'll talk about a little bit, that really helps as well. And so that advanced training program, it's 34 years old. I've been teaching it now for 4 years. And when I came in, we redefined it just a little bit. So it was more population health focused, value-based care, and really taught this model of clinical best practice integration. And so everything I'm showing you is what we teach in the class as well. I thought I would just show a smattering of projects. Just last year and this year, we actually have class concurrently running, although I'm not teaching there, I'm here. Somebody else is covering that, but these are just some of the projects. And you can see here, the colors correspond to the region at Intermountain. So the blue, that's the new part, SCL Health, that joined Intermountain 2 years ago. So part of our play is bringing people together from different regions to learn to work together, because that's really how you're going to get the power of this large organization, which is really what we're going for. So I thought I would just share, now that we're working in this way, how do we know how things are going? So one of the pieces when we think about what underlines our evidence-based best practices at Intermountain, I'll share the model in a minute. But prior to that, I just wanted to share this figure on the left because I know your organization, just like everyone, is focused on these things as well. So you sort of think about that term clinical evidence-based best practices. It's that big circle. There's a ton of stuff in there. Nursing best practices, respiratory care best practices, pharmacy best practices, physician best practices by specialty, by primary care, all that. That's what's in the circle. Within that, occasionally we say we want our technology to help support it. We think that technology, the electronic medical record or other, can help nudge people or do things right at the point of care when they need it. That's what's in the pink. What's in the salmon color is the clinical best practice integration projects. So Raj, why is it a subset? It's a subset because in the model, we say if it's a CBPI project, that means we are measuring the team's adherence to that best practice. That's the key here. We need to know what the frontline teams are doing. And more importantly, they need to know what they're doing so that we can have improvements. That setup means, yeah, we do the stuff in white, we do the stuff in pink, purple, pink, and we do the stuff in salmon. If you think on the right, that's then how we think about decision support. What kind of decision support do we need when we're doing best practices? Well, 2 years ago, we had 9 EMRs when we merged. We're going to 1. We're going to Epic. Legacy Intermountain was on Cerner. The new org SEL Health was on Epic. So that just made both contracts in place, and the decision was made to go to Epic. Here's the thing. When you're using your EMR and other technology, there's like a bunch of standard stuff. If all the neurosurgeons get together and can come up with what's the best practice and then the order set that supports it, I'm just going to call that standard work. That is amazing because now there's a way of tracking a bunch of stuff. But the complex and high-tech stuff isn't just routine stuff we do like order sets. There's a lot of technology we need to help people guide to what we need to get done and then make sure they're doing it as well. So that's how we philosophically approach our technology. We do it all, standard, complex, high tech, but the high tech only has to be for the really most visible things that we want in the org. And a lot of that actually ties to clinical best practice integration, because you can't just give it anywhere. Otherwise, at a certain point, somebody is going to come along and say, hey, we're running out of resources. What are we pointing our high tech stuff to? So prioritization and alignment is super important. Okay, so a few years ago, we had a CEO, fourth CEO, Mark Harrison, came in, and he was like, he had trained actually with us and then went off to the Cleveland Clinic, came back, did a lot of leadership there. And he noticed, hey, Intermountain, when I practiced here, we had a lot of care process models that were guiding us, sort of the algorithmic, 8 to 30 pages saying, hey, what happens if a kid has pneumonia? How do you diagnose, treat them, all that stuff? There were hundreds of those. The key that he pointed out, which I think was true, was we weren't measuring if we were doing that stuff. We just were doing it. Is that a problem? Well, it's not a problem if you're tracking your outcomes and the outcomes are really clear and the teams are doing what they're doing. But not a lot of outcomes are easily apparent. And sometimes, unless you have a method, you don't know your processes that are linked to the outcomes. So we did a little bit of a shift and said, okay, we're going to go from 300 care process models down to 2. And we're going to see if we can get high adherence to the key interventions. He asked it to be 100%. We did not do that because we know a lot of the times there's really legitimate clinical reasons why it shouldn't be 100%. In fact, nothing should ever be 100%. Otherwise, it would be AI and robots. However, maybe 80, 85% is what you're really driving to, and you capture all the reasons people are not doing it. And then you have a system to see if they're right or not, or it's an opportunity to learn. What's our now current challenge from 2018? Now we are designing and implementing a systematic approach to driving high adherence to evidence-based best practice throughout Intermountain. 6 states, 400 clinics, 33 hospitals, every specialty in primary care. That's our challenge. So how is CBPI different than before at Intermountain? Couple things. One, we systematically prioritize at the level of the care process model. A governance group can decide what are we going to measure and what are the key leverage points. And then the second is we actually go build the measurement system around those because we've agreed that's what's important. And then here's what we focus on, helping the teams get adherence to those metrics. So here's the model in a nutshell. There's a lot that goes into the model, and it's actually on our website if anybody wants to see all of the stuff. But the key is these 5 steps. 1, have the clinical team search, develop, and identify that best practice. Turns out, for example, venous thromboembolism, there are national guidelines in chest. Just like your organization, you have experts in all these different areas who are sitting on all these panels and writing these things. And in ours, we have 2 of the co-chairs of the chest guidelines. So yeah, they know it, but we could have also searched it and pulled it out. So that thrombosis group knows that best practice. The second is we have the clinical teams define a few key leverage points that have been shown. If the teams do those 3 to 5 things, it's going to lead to a better outcome. And then we certify that level of evidence. How good were all the collective studies that prove that? By the way, that's not how we do. I'm a researcher too. That's not how, or maybe a reformed research, I don't know, but that's not how we do research always. We're not measuring all the team leverage points, but that's what we're trying to understand. That doesn't always turn out to be the case, and that's okay. We just want to know what's the evidence, how strong is that evidence, because we're going to drive hundreds or thousands of people to be doing this. We really want to know what's the strength of the evidence. Third, we create a measurement system. That measurement system has to be really done at the level of the front line that they need to see it at. Then so for some people, it's like minutes refreshed. Some people, it could be months refreshed, depending on the patient population. Fourth, this is where I think it gets super exciting. You get to implement and drive high adherence from current state to ideal state, each site, and then collectively. We do a lot of QI and implementation science here, understanding those barriers, devising the strategies. We test it in pilot, and then we spread almost every time. Lastly, sustain. I'll show you some sustain projects, but really, once we've put in the effort, we got that best practice. Talk about punching people in the gut, coming a year later and saying, oh yeah, we used to do great, and now we're no longer doing it because we moved on. So how do we sustain that? And then see if somebody's drifting and then correct that drift. So I thought I would just show you the current projects that are along the pipeline. So you can see here, they're color coded. So you've got a handful under the define and certify. You've got a couple in measure and report, several in drive high adherence, and then there's a sustain on the right that I showed you. I'd like you to notice, these are a mix of kid and adult, inpatient, outpatient things, because this is a whole system play. We have kids and adults, and we have in ambulatory settings and hospital settings. We do skew more hospital settings. There is a lot more evidence there, and we are working hard to bring more ambulatory stuff to the table. We have some, but we definitely want more. And so this is how the current projects we have. In a couple of minutes, I'm gonna, on the sustain, talk about project number 4, acute ischemic stroke. And then I will touch on the one underneath it, low tidal volume ventilation, for a minute. So how do we keep track of it at the executive level? First, we have a goal, and the clinical governance of Intermountain looks at the goal, and the number of projects that are meeting the milestone in those phases is the goal. I just showed you the projects. So currently, as of June of this year, we ended where the teams are well above stretch. Okay, yay. So in the boardroom, people will be very excited. So what does that mean? We have a view of each project, and the color coding is the same color coding I showed you 2 slides over. So how many are in define and certify, measure and report, drive high adherence, and sustain? So on the bottom, you can say, hey, Raj, those 1, 2, 3, 4, 5, 6 projects are all in sustaining. That's pretty good. Those have been sustaining for 4 years, even during the pandemic, because we had a system. You'll notice a few things. There are a couple of things on red. So the leaders can zone in on the red. Maybe your org is slightly different. People just don't focus on the negative and be like, hey, what's going on here? How are we going to fix that? But you've got what the project is, what are the players, what their roles are, notes about it, what the measurement is, some of the clinical stuff. And that's how we're sort of measuring it at that system level. Okay, so I thought I'd walk through an example of how one clinical team uses the model. So adult stroke. Okay, so you can see here, there's the bar that shows the model that I just shared. And fortunately, the neurology and cardiology groups got together and agreed. That doesn't happen all that often. And they're like, hey, there's a best practice to have stroke care. And they've published it. And there are studies that say how many people aren't achieving it, or one hospital's achieving it. We want to do it for every hospital, including our rural hospitals, one of them that only has 14 beds. And 4 of them are ER beds. Okay, so we had the team define and certify. Here's what they said. We have to give that clot-busting drug when a patient rolls into the ED in under 60 minutes. That's the best practice. That's their primary goal. Secondly, they have a door to getting to a neurologist in less than 10 minutes. And they have to have a CT in less than 15 minutes. So, built the measurement system. At Intermountain, we are pretty fortunate to have a lot of heavy investment in data and analytics. And so that is one of the legacy things we have really appreciated. So we can track the heck out of stuff. Although, of course, like anywhere else, no one ever thinks we have enough. So what were the strategies the team used to drive high adherence? So decided to first pilot in 3 EDs. By the way, this was the project that came up when our CEO said, get to 100% adherence. That meeting took place in June. The goal was to get it done in 3 EDs by December. It took 3 months to organize the team, the central team. I was one of the people. Although I got to be honest, I was at the back of the room wondering, boy, this is really going to be hard. I don't know who's the poor sucker who's going to be on the hook for this. Turns out there were some SVPs who were there that were on the hook, but I was one of the team members organizing behind the scenes. So we had to create the model. We had to pilot it. We had to get that system buy-in and prioritization. Yes, nothing like the CEO saying, I want to see 2 things done, but that doesn't mean everything is organized and ready to go. We have to identify local champions at those 3 sites. Then we have to figure out the communication, education, training. Then we have to build a measurement system in like 3 months. So then we got our baseline. And then Q4, October, November, December, we rolled it out. So what happened? Okay, so I'm going to take you back before 2018. This is the goal they picked from they certified. It's also national. Hey, a lot of your patients should have this clot busting drug in less than 60 minutes. In 2016 and 2017, for a portion of the hospitals, because it was legacy Intermountain before the merger, The median door to needle was 62 and 62. That was after we spent $50 million on telehealth, because we jumped in early, and we hired a bunch of neurologists. So it wasn't just technology and resources. In 2018, using the CBPI model, 3 out of the 20 EDs that adopted it, because that was the plan in the pilot, just having those 3 improve their processes, dropped for the first time as a system at Intermountain stroke care at 57 minutes. Faster is better because you save brain. 2019, then we implemented in the other 20 hospitals. I did not think we could do it in a year, but we did. That made it 52 minutes. 2020, it was 47 minutes. By the way, that's the first year of sustaining. But wait, Raj, COVID happened in 2020 and ERs were then empty, but then got super full, or really sick people. We're focused on respiratory things. Yeah, we had some clots, but some strokes, but how did the ER docs and the neurologists do the best job they had ever done? Because they were set up to do it. So even though we had the wave just like everybody else, everybody was on their stroke care. Okay, so that's implement, drive, high adherence. What about sustain? Last year, 2023, 39 minutes, median door to needle. I have a friend who was hiking in southern Utah, owns a house there, owns it, and he was feeling kind of like confused. They drove him to the nearest ER, which was about an hour and a half away, went in around the ER, and within 12 minutes, he had a CT scan. And then he got life flighted to get care. Amazing to see a rural facility that can do this just like the big academic centers that we have. Okay, well, so you reduce the median. What about the percent people who are getting this care? Turns out in 2018, it was only 74%. What's the best in class care in the country? It's supposed to be above 85%. When did that happen? 2020, during COVID. Then year 1 of COVID, or year 2, and then in 2022, and now 2023, still above best in class, sustaining. All right, so I just shared a story. 23 emergency departments did this. They are, okay, the math just worked out this way. 23 minutes faster door to needle for those EDs. Took us 6 months to pilot, 1 year to scale, and we've been sustaining it for 4 years. I want all of our stuff to go like this. And I want all of our stuff to sustain, because I think that's what the patients and the communities deserve that we serve. All right, we also publish this. Took us a little bit of time to publish this, so it just came out a few months ago. If you want to read all of the typical ways we describe this in research, it was a type 3 hybrid effectiveness implementation study where we were not testing, does it work? Because that's been shown time and time again. The question was, what are the processes that need to be in place, and are those getting better over time? Because that's really what we're all trying to learn. You might think Intermountain has a command and control system. Nope. It is not one person says it, everybody falls in line. It is still a lot of influence, leadership, and figuring out how to do it together. So those 21 EDs, although they can report up to a structure, that structure was created halfway through this project that was not there at the beginning. And yet the team still did some good stuff. I still think structure matters. I'm just saying it's not always structure. All right. So now this is another view from 2015 to 2024. You can see here the timeline on the x-axis, the y-axis is the door to needle, and then the time to better care. Okay, a couple of things. That's the CBPI pilot I showed you in 2018. And then 2019 is we implemented everywhere in legacy Intermountain. And so last year I said we were 39 minutes median door to needle. Well, we just merged with another health system, SCL Health. So basically, now we have 8 other hospitals that we have to implement and see that we're doing that. That's what clinical programs and healthcare delivery institute are doing together. So what can you do when you have a system like this? Here's what I'll say. Back in the day, if you were going to give IV thrombolytics, it had to be less than 4.5 hours. And that's what we were doing. But then in 2019, look at what that says. Hey, wake up, extend. Those are two massive trials that said, actually, you can give Alteplase if it's more than 4.5 hours. We were able to implement that really quickly. Also, like other health systems, we switched to tenecteplase, which is a little cheaper. And, there's some question, is it exactly the same? But a lot of people are doing it, and we wanted to learn. So we switched to tenecteplase, and we're learning because of the ACT and TRACE-2 studies. What about mechanical thrombectomy? There are IR suites where interventional radiologists can go in and snake that clot and pull it out. And in 2015, you could do it if they presented within 0 to 6 hours. But then in 2017, we learned you can do it from 6 to 24 hours. So we had the machinery, the chassis to build that on so the interventional radiologists could go do their thing. And because we own a lot of air facilities, because we're so big, people can pick up a patient and fly them to where they need to be really quickly. And so when you build this, when new evidence comes, our providers know it, and they just want the health systems help to implement it. So that's what we're doing here. We have a colleague who does data with us, who actually has been marginally involved in this project. He was looking after his grandmother and, left the room, came back 10 minutes later. She was unresponsive on the floor. He called EMS. She rolled into one of our facilities, and then she was life flighted. She had an NIH stroke scale that was really not good. She left the hospital 48 hours later, totally fine, as far as they can tell, because of this system. He's a pretty big believer now in what he does and why he does what he does. So talk about the engagement of the team when you're really aligning systems to do this type of work. Okay, so what I shared with you was mostly stuff that's happening in Utah, because we're known for that. But our challenge now is we are in 6 primary states. We cover 640,000 square miles. We have a lot of people in rural Intermountain West who do not have the same access, but we're going to hold ourselves to the same metric because it still is the best evidence-based care that we know. So we are learning. So now we have a model that has governance with executive steering committees, helping the clinical programs say, commissioning the work they want to do. I'll show you that, who's on that in a minute, just so you get a sense of how we're organizing. I just showed you that CBPI model. By the way, that shortened timeline to routine care took us 2 years to scale that project, stroke care, and we've been sustaining for 4 years. That's what we want to be known for now, is how do we actually sustain it? Because we're really tired of having to come back and do it again. And we want to partner with other health systems to learn how are they doing it. Because there's no magic answer for us. And we are really hoping to learn with others as well. Here's our, I'm just going to give you one other example story, low tidal volume ventilation. In 2001, that was published in the New England Journal of Medicine. An adult shows up in the ICU, has acute respiratory distress syndrome, having trouble breathing, needs a mechanical ventilation to help them breathe. Turns out you have to give them the tidal volume, sort of the breaths that they get and how much you want to blow up the alveoli or the balloon that allows oxygen CO2 exchange in their lungs at just the right amount. Give too much, causes damage. Give too little, they're suffocating. There's a certain amount to give. That was done in a clinical trial published in the New England Journal of Medicine. And one of our informaticists used a computer to build a computer algorithm to run it and then guide the docs on what to do. Turned out that computer algorithm did really well. And so, in 2001, we got known for that. And a lot of people were super excited about using computers to nudge. But for a long time, that was only done in one of the ICUs. In 2018, Dr. Colin Grissom and I partnered together. We brought the Healthcare Delivery Institute. We used the CBPI model. And then within 2 years, he had implemented it at 22 hospitals. And then the reason that says the ATP, that class, 2.0, that's sort of an internal term. We had redesigned it a little bit. These are the examples we're now sharing. How do you get to scale? But what's cool is now that we've merged, we have another several hospitals that we've got to do that with. So that's what we are embarking on today. This is that clinical impact story. I just showed you the stroke example, how from 2017 to 2023, those hospitals, it was in 2 of our regions. We define our org into 3 regions. That door to needle time went from 62 to 39 minutes. Hey, that really helped 554 patients with acute strokes get better care. We predict if we can do this in the new place we have just merged with, we're 2 years in, so not just, there's an additional 480 that'll get better care. Well, Raj, what's their care now? Can't tell you. Why? The data systems, they're not totally aligned. So we have to align them. If you look at the left, the ventilated story I told you of Dr. Grissom, that one, his journey, that team went from 50% adherence to the best practice to 85% adherence. So 1,500 people getting better care. And he now has data. He's the first in the system to have data of the new part of the org. They're at 50%. Why are they at 50%? Everybody thought they were doing it. But if you don't measure it and show it, people don't really know. We do things for women who are pregnant. We do other examples as well. Just wanted to share these. I think I just wanted to end with governance matters. How you can get this on the radar of busy executives that are doing all kinds of things. What's our CFO doing? We know we're not where we need to be in terms of running the business. What is everybody else doing? A lot of different things. We're trying to build everybody together to say, this is how we want to track and improve clinical care. These are the 9 clinical program leaders. There are 18 of them. So I've got 9 docs, and then Cheryl Lee has 9 executive clinical directors. Generally, it's a doc, nurse, dyad. So you'll see those are the 9 areas that report to me right now. And they cover behavioral health, cardiovascular, women's health, neonatal, surgical specialties, digestive health. That acute and ambulatory med specialties, Dr. Grissom, he's the one who did the low tidal volume. That includes ED, trauma, ICU, med surge, and urgent care, and all of the ologies. I've known him for a long time. So he tells me he's having a career high right now, spreading these best practices everywhere with Gina, his partner, nurse partner on the right. Then we've got MSK, oncology, neurosciences, primary preventive care. So we're trying to cover the scope of what we look after. Don't worry about the names of the people, but if you look at the titles, the executive committee is led by our chief clinical officer and chief nursing executive. I'm just a member. I'm kind of like their chief of staff, organize the meetings, set the stage of what we need to do. The steering committee, they're all the implementers, CNO and CMOs with supporting leaders. I've been at Intermountain 23 years. I've never seen such a cross-disciplinary team care about improving care in the org as a group. Everyone's always cared about it, but now we have a governance structure that you can see it. This is the key for us. We have clinical program councils. So those 9 clinical programs, they have a council. They're enterprise-wide. They are not operational. They have operational counterparts in each of the regions. As those dyads all get together, the 8 of them, they determine what are they going to work on, and then they go work on it with help from the steering committee and exec committee. I guess I thought I would just take the opportunity to advertise, because we had some amazing people from your org and others who have come into this class. I thought I would just share last year and this year who's coming. It's a really great internal use that we have to have this, and then we still share externally with others who want to come as well into the class. And if anybody is interested, there's the QR code link. That's our 2025 classes. We actually have 3 classes. We do a all in-person class, all virtual, and then a hybrid class. The all in-person is actually, we reserved for senior leadership the last 3 years to kind of get the merger really feeling real, where different people can get together and all kind of collaborate and get to know each other. Okay, I timed it to finish. I know we've got 10 minutes left, but I thought there might be some questions.
Yeah, thank you, Dr. Srivastava. If you have questions or comments, please use the raise your hand feature. We also welcome you to type your questions into the Zoom Q&A. To start us off, we have a question from Molly. She asks, does your team have an established process with your IRB for expedited review of these projects where the clinical intervention is already proven successful, but you are working to implement it in your system?
Yeah, thanks for that question. So I've had 3 leader roles at Intermountain. My first was actually the assistant vice president of research. So during that time, we definitely established that, where, hey, this is well done quality improvement. This is really, we're just trying to align it. And our IRB was super excited to undergo that conversation. We had a large stakeholder group, and people really defined, if it's quality improvement, this is the way to go. There are some challenges that are important to acknowledge, though. So some of us still write grants. So we just got that low tidal volume ventilation. We had $1 million grant from the NIH, and we wrote it as a hybrid effectiveness trial. Well, they treat it just like a drug study. So there's a DSMB and all that sort of stuff. So of course we went through the IRB. Here's the thing. Our IRB chair wrote a letter saying, this is waiver of informed consent. And these are the rules and the regulations, and this is why we say it. So we are not asking our providers to enroll every single patient. This is just the best practice, and we're going to go that way. So it's been a really cool discussion. I hope that answers your question.
Does anyone else have any questions? Once again, feel free to put them in the chat, or you can also raise your hand. All right, so it looks like we got a question from Ivana that asks, how did you establish financial models to evaluate ROI of different projects?
Yeah, that's a great question. So we got started first to do this, but just like any good system, people want to know, hey, we're investing, we're organizing, what are we getting for it? About 1.5 years ago, my boss, the chief clinical officer, asked me to undertake a partnership with finance to do a framework that we would analyze and use. I said, great. I've tried to do it before. I need 3 things. I need 1 finance leader. They have to be super creative, and they have to be optimistic, because we get paid, of our $17 billion revenue, 37 cents on every dollar is fee for value. So $5 billion comes to the health system in January 1st, and we have to run a fee for value piece right along a fee for service piece. So I cannot have somebody who's mired in one way or the other way. We got to be able to be fluid and allow the teams to do what they want. So that has embarked an amazing journey of, so by the way, he set me up with the most Amy Church, VP of Finance, who is fantastic from the new system. And we got together, chatted, and our teams have been working for 18 months on this. So we created a playbook. So here's the problem. Going back in time to explain it is kind of tough. Going forward, we thought we have some stuff that we're doing going back in time, cost effectiveness, ROI type things, cost benefit analyses. They're very researchy, I would say, and I'm not sure are going to sway administration, high level leaders who are very used to operationally, what are we doing going forward, as opposed to looking back with a lot of assumptions, although we're doing that. But in that low tidal volume ventilation, we actually have an active project since it's ongoing of, hey, what's the money we spent and what's the money we saved and for fee for value versus fee for service. The back of the envelope when we did it as a team said it saved, well, saved is a challenging word. The ICUs spent $1.5 million less the year they implemented it at scale. We're now writing that up to be able to explain that, but it's an ongoing challenge we're going to have. I love that we're talking about finances. I do not want to get in a situation, and I've never seen it at Intermountain, but I can see it's going to happen. Hey, it costs this much. We know it's going to help people, and then we're going to have to duke it out. We're just trying to come up with a model. My model is whatever we come up with, can it go to the general ledger? So if we end up cutting expense for the hospital and they want that, they see it on their general ledger. So that's sort of the team that we're going with. And then, Andy, I saw the next question is, I may have missed it, what sort of curriculum is covered in ATP? Actually, it's quality improvement. It is the clinical, it's both sort of a typical quality improvement life cycle project. People come in teams and do the project. But then we have this implementation science CBPI model if you want to try something at scale. By the way, it's only 11 weeks, so it's not like anybody can change everything in all the ICUs in 11 weeks. It took us years, but we really trained teams to have the tools to try that. We also have a lot of speakers internally and externally who come and talk about this kind of journey. We talk a lot about health policy and how it actually should be applied. And then this financial playbook we came up with, we actually have that VP of Finance come teach it with one of our directors. There are 2 classes. People are super excited to say, oh, if I get this from Blue Cross Blue Shield and I get this from our value ACO, how does that look on the same problem? So we're trying that. I hope, Tim, that helps a little bit. We also teach leadership because I think if you're going to do something hard, you really want to understand the principles of leadership and how it applies to your project. But the key is you have to have a project. And ideally, you have a project that your system cares about, and then you're applying it during the class time. Hope that answers your question, Tim.
It does. Thank you.
And then it looks like next we have a question from Heather that asks, how do you align metric needs when the system wants one thing and the operations team wants another?
Why do you think it takes so long to build a measurement system? That is what we decide at the beginning. We are not creating a measurement system just for the clinical team that the operation team won't buy off. We resolve it when we do it. Is that easy? No. Is it worth the extra pain at the beginning? Absolutely. Because it turns out the operators have budgets and resources to help the clinical teams. So everybody's got to align when we're going in together. That's the advantage of this model, is people are seeing it together as we create it. It's not one group does it and then comes over and tells another group.
And then it looks like we have one more question. Someone asked, have you collaborated with the population health team at Intermountain? And if so, how?
Yeah, so we had a separate population health office. It's morphed a few times, just like everything. And we now have them as part of this class. So last year in our merger class, we picked one condition, low back pain. You know, it's only a $15 billion problem in the US. So we brought neurosurgeons, primary care docs, and everybody in between, including finance and the population health group together. And we broke them out into teams, and then they focused on things. Oh my gosh, it was and we had our insurer come. It was fascinating to have everybody's point of view of all the problems. And then as people went through and could see it, there was like an appreciation of whose data are we using? Are we believing it? Are we starting to see eye to eye? It was a great cohort to kind of get through. So yeah, we have to collaborate with them only every time that we can.
It looks like we are out of time for further questions, but once again, thank you for taking the time to give this talk. Again, in closing, please join us for our next seminar on November 5th at noon Central Time. And that concludes our presentation. See everyone next time.
Thanks.